we'll start our practical courses today on cellular damage and the mechanism of adaptation. I'm having the lesson videotape so that I can upload it on my YouTube channel and so that you can see it anytime. All right? If there is, however, any objection to this, just tell me and I'll just turn it off. I have no problem with that. It's for you, actually, not for me. I don't make money out of this. So it's not my interest. I'm not interested in that. It's just for you. All right. So as I told you on our first communication, I believe in interactivity. That means we must communicate with each other, and this is mandatory because in this way you have some increase in your emotional status so that you can communicate with the patients. If we have an education that is impersonal, we don't talk to the teacher, we don't communicate with anybody, it's very, very difficult to communicate with the patient. So that's number one. And number two is, I do not believe in starting from theory. That's not my way. We start from the problem of the patient. This is what we see. Science starts from remark. We explain the problem, and afterwards we look at the theory. So, in my opinion, it's the other way around. This is called experiential learning, and it's not my idea. It has been implemented for the last century. However, here I do not know what everybody does. So, these are the two principles with our lesson. So, you can feel free and ask me anything you like, but if you ask me something from theory, we'll Google it together and find the answer. Because Google knows theory better than me. There are other things that Google cannot give you. And these other things, I'll try to give them to you as a doctor. Is that clear? Is it okay? Yes. Nobody's bored, all right? We're okay. We're not pathetic, not passive listeners. Why have you sat up there? Is it okay? Can you see the slides? Is it fine? All right. Come, my friend. So today we are having the lesson here, and you'll have a look at the announcements to see if we have another lesson on Friday. It depends whether the conditions in the campus are normal, or we'll follow the announcement and we'll have two lessons next Monday. I'm starting the lessons of cellular damage and inflammation. These are 4 lessons we'll have to do together. All right, so we'll see. You have a look at the announcements and see how we'll do the lessons. But today we are here. All right? So, no, not this one. Here we go. We have an aged woman, 70 years old, who has a blood pressure of this, you see the value here, 160, 105 millimeter for many years. So what is this diagnosis? Hello, please. Take your seat. Come on. Take your seat, please. So how do we call this if somebody has such values of blood pressure for many years? How do we call it? No, yes, please. It's hypertension. And this hypertension is not treated properly. That means she does not take a medication. So, let's have a look at the 2 kidneys of this woman. We have an abdominal ultrasound, and look at this size of the kidney compared to this one. What is the obvious thing you have to say? Have a look. This kidney and the other kidney. What can you see? Compare the 2 kidneys. What do you think they are? You can say anything you like. We are not doing exams now. No. Nothing to do with exams. No. Not exams. We're just trying to think. That's what we try. But we think loudly. We talk. What we say, we talk. There is nothing that you should know and you don't know. Is that clear? So don't be embarrassed at all. So tell me, my friend, which kidney do you think is abnormal? This one or this one? This is from a patient which had a long history of hypertension. And her kidneys have been affected. by high blood pressure. All right? Can you tell me here? Which is the abnormal one? One is up or the down? Have a look. There is an abnormality in this kidney. You are right. However, its size is normal. So the other one, which is of diminished, of reduced size, is the abnormal. When in an organ we have a decrease in the number of cells or in the dimensions of the organ, this is called atrophy. However, as, what's your name here? Sarah. As Sarah told me, this kidney is also abnormal. Why? Because if you can see, there is some granularity. You see these tiny, tiny granules on the outer surface? What are these? These are small foci of necrosis because due to hypertension, the small arteries, the arterioles of the kidney, have become thickened, and so the tissue does not take enough blood and it becomes necrotic. So this kidney is also abnormal. However, since the other one is so small, the main lesion is atrophy. All right? So, how can atrophy be explained? Atrophy is explained when the tissue does not take the proper amount of blood. However, this should happen on a long standing base, because if we have an abrupt arrest of blood supply, what will be the result? If the blood supply to a tissue is abruptly interrupted, what happens? What happens to the tissue? No problem. No problem. What do you think? Yes, please.
Ischemia.
Ischemia, and the result is, does the tissue? Necrosis. However, this happens acutely, right? Here we have another. We have a long period of low blood supply to the kidney. Why this? Because, do you know, hypertension with what other condition is related, so that we can justify the lower blood supply that this organ takes? Where does the kidney take blood from? You remember the artery that gives the celiac aorta, the branch, and goes to the kidney? Do you remember this artery, what it is called? The renal artery. So, is there something you can think or you have heard that affects the renal artery, the main stem, not the other branches in the organ, which can be related to hypertension? Have you heard what disease is the one that narrows the lumen of vessels? Have you heard that? It's very common. Everybody speaks for this. Yes, please. Excellent. So this hypertensive woman also had atherosclerosis. So the blood supply coming to the kidney has become less and less on a chronic base, and this justifies the reduction in the size of the kidney. Is that clear from this image? Do you want me something to explain more? You have here the questions. Of course, you can see that there is a problem, because if you have diminished blood supply, then the kidney itself may cause hypertension, and this is secondary hypertension, not the hypertension we know that everybody has, almost everybody. If the kidney does not take the correct blood amount, it does not produce the correct amount of what? Of hormones, yes, but how is the endocrine function is triggered? If the kidney is not properly, does not take the proper amount of blood, what does it cannot produce?
No, I would say that
How is this endocrine organ triggered to secrete renin? Anyway, the kidney does not take enough blood, so the urine is not as expected. The amount of the urine is in accordance to the blood supply of the kidney. If the kidney does not take enough blood supply, the urine is less. So the apparatus, that's what you said, the juxtaglomerular apparatus, secretes renin, and then this is the cause of hypertension. However, in this case, the hypertension was of the usual type, the idiopathic hypertension. However, there is an extra reason that this woman has hypertension. So, and the cellular organelles in atrophy are lysosomes, and you can see that cellular atrophy is mediated through increased protein degradation. Now let's hear. Here is skeletal muscle, all right? And we have a man who has repeated trauma to his upper arms operating a jackhammer. He hurt himself. He now has hand and forearm weakness. Which is the forearm? So yes, this is the forearm and hand. Has weakness. If we have weakness in some part of the body, what do you think? What do you think is wrong? And we have weakness. Yes, please.
The atrophy of muscles.
One thing is to look at the muscle, and the other thing is to look at what does the muscle need to work properly. The nerves. So if you see that somebody has some part of his body and is weakened, you'll either look to the muscle and its blood supply, is it adequate? And the other, you look at its denervation. So what happened here? Which of these muscles do you think are abnormal? There are two kinds of muscles. Can you discriminate them? Can you tell the difference between them? Who can help me, please, and have a discussion? Yes? Who can? Yes, please.
They're in this picture.
So, come and show. Here is the, see that?
Yeah.
Okay. Two kinds of skeletal muscle fibers.
You have the swollen round muscles.
Yes, and those. What's the difference? Some are smaller.
Yeah.
So, in accordance to the previous case, which are the abnormal ones? What do you think?
I think the bigger ones.
No, these are the normal.
Oh, okay.
So, how can the smaller one? And what cellular disorder do they have? Atrophy. How can this is justified now? In the kidney, we made the justification. Here, what happened? So we made the microscopic description, and we see that these smaller undulated fibers are grouped together. So, can you think, after this repeated trauma in the region, what justifies, oh, it's nice here, more comfortable. I'd better sit here. Doesn't sit here better, it's nice. Table, very nice, all the other are. However, despite the fact that you are back, you cannot talk to each other. Despite the fact that you are separated. Now, can you tell me what happened to these cells and they became necrotic? What do you think? What do muscles need to contract and move the part of the body? What do they need? One factor is the blood, of course, and there's another factor. They need something so that they work. What is that? Think. The muscle fibers, what do they need to move? What do the muscle fibers need to move? And yes, this is on the biochemical level. On the anatomical level, what do they need? Nerves. So, as he was injured, what happened to the nerves? They had a problem. So, the muscle who did not have the correct nerve stimulation became what? What did it become, Sarah? Atrophy. That's right, my dear. So, did you understand this symbol? Yes. clinical medicine is very simple. But if you look it from the books, you get lost. So we start from the observation, not from theory. That's why. So that we know what's happening. So have a look, the cellular atrophy. Yes, we have, of course, we have the biochemical background, lysosomal autophagy, increased proteasomal degradation. These are the mechanisms of atrophy. However, the stimulus for atrophy is nerve damage. Okay? And you see, these are the pathologic fibers, and these skeletal muscle fibers are randomly innervated, and this is the key factor which leads to atrophy, nerve injury. All right? And then we can explain why the atrophic muscles form a group. In this case, they become re-innervated. However, if another stimulus damages this nerve, then we have a group of atrophy, and they are all together. At the beginning, they are separate. The atrophic muscle fibers are separate. However, through this mechanism, then they come all together, the atrophic muscle. Yes, you can ask anything you like, but always in English, because I must speak English in the course, not Greek. Trump told me that you're fired. No, President Trump. He had a TV show and said you're fired. You know that?
The Apprentice.
He said, get fired. He told me, if you speak Greek, you're fired. That's what he knows.
It's called The Apprentice.
Yes, please, yes.
If the problem here was...
We'll say something not too serious, all right? We should be serious, not necessarily appear serious. We should be serious, not necessarily appear serious. That's optional. If somebody wants to appear serious, it's okay. But we must be serious in what we do.
Seriously going to kill.
Yes, please.
If the problem here was not due to the innervation, it was due to the blood supply.
No, the innervation was the main problem.
Yes, if the blood supply was the
The
main
blood
problem,
supply, it would be
what we will see?
hemorrhage, because in this case of trauma, the blood supply means that the vessel is cut. So we have hemorrhage. There is not enough time to have atrophy. We have hemorrhage, okay? As far as skeletal muscle is concerned, not other cases. What sort of tissue is this? Have a look, it's from a young woman who has a newborn child, and she has nursing postpartum. That means she feeds the child, all right? So what tissue is this, please? It's the mammary gland, yes, of course, but that's right. It's glandular epithelial tissue, all right. So here we have the glands, in which in the breast are called ducts. So female breast has lobular units which are composed from lobules and ducts. Why is have a look at is the cytoplasm enough in these glands, or is it less? Is it reduced? What color are the cells? Have a look here. Those who appear more dark have less cytoplasm. That's why they do not take eosin. They take hematoxylin, as we said before yesterday. By chance, if somebody had recorded the lesson, he can send it to me so that I can upload it, because I did not manage to have it recorded. I just have the sound. Possibly I'll upload it as a podcast, the lesson. However, if somebody has recorded it, he can contact me and send it to me, so that I can upload the tape with the slides, because the one that we managed to video to have it taped, it just shows me talking, and it won't be very for 1 hour and watch a man talking without so, and me particularly, no, it's unbearable. I think it's unbearable. No. So these cells have enough cytoplasm, so they appear pink. Right? They have Asian. And what do they produce?
Milk.
Milk. This is milk. All right? Excellent. So, this increased cellularity has to do with a particular hormone stimulus. So, this is a normal, a physiological state of these glands are too many. Why? Because the hormones made the tissue proliferate, but proliferate in an ordered way, not proliferate without control. This is a proliferation under control. So, when the size of an organ increases and the number of cells increases, however, under control, that means now that we have the glands in a specific amount, this is the trigger for hyperplasia, because this is hyperplasia of the epithelium cells of the breast. Okay, so estrogen and progesterone, which are the hormones who balance between the period she's carrying the baby and after birth, are responsible for this hyperplasia. If the hormonic stimulus does not affect the gland, then it will become normal. Again, it won't continue in this state of increased cell proliferation. You would like to ask me something? Yes, please.
What is the difference between hyperplasia and hypertrophy?
Hyperplasia is the increase in the number of cells. Hypertrophy is the increase in the size of the cell. We'll see that next. Okay? So, these are receptors which bind to cells, receptors for hormones, estrogen and progesterone. And they cause mRNA transcription, and then we have a protein translation that promotes cellular proliferation and gain of function. However, when we talk of hyperplasia, this is a disorder which is still under control. In this case, under hormonal control. Okay? Now, have a look at this. This is a breast of a male. A male. The male breast does not have lobules because it does not produce milk. It has ducts, however. Can you please tell me, is there something wrong with these ducts of the male breast? I can see their lumen. Here is the lumen of the ductular epithelium, the glandular epithelium. This is the stroma, connective tissue, and some adipocytes here, all right? Is there a problem with these ducts of the male breast? I can see that it's a ductular, it's glandular epithelium, because they have lumen. See the lumen? What color are they? What's your name, dear? Yes, Katerina. What color are the glands? What color do they? Tell me the color. These are the glands, my dear. That's right, that's correct. It's not high science. It's just what we see. They are dark. Excellent. Why are they dark? Who can justify this microscopic finding? Katerina says that the glands are too dark. Why? What compartment of the cell is stained in such a way that makes the glands dark? Which part of the cell? We don't know. We have the hematoxylin.
Yes.
What part of the cell does hematoxylin stain? We said it in the first lesson that before. Yes, you had your camera on, you were watching, not just take the camera and then go and cook and chat.
Yeah, I don't remember.
You don't remember, but you found it. It's okay. No problem. You found
I
it.
was doing what I
Yes.
don't remember.
Don't remember. But you found it nonetheless. Yes, okay. So there are many nuclei. So this is some form of hyperplasia. All right? So why are all these cells hyperplastic? Similar to the previous case, we have a hormonal stimulus. So despite the fact that these cells are hyperplastic and not neoplastic, that means they are under control, if we have a male with such a problem and his breasts become big, we have to examine his hormonal status, because which hormone may be increased in this male so that his breast ducts become hyperplastic? Estrogen. So we have to look, why does this patient has gynecomastia? That means increased breast. Is there some place where estrogen is increased? Can we find the cause of the increase in estrogen? So we must make an investigation. It's not just that he is fat. Why? Because apart from the adipocytes, we see an increase in the number of cells of hyperplasia. So have a look. We may have an estrogen secreting tumor. For example, from the testis, from the adrenal gland, and it produces estrogen. Estrogen increases. As a consequence, the number of cells in the ducts multiply. Another case, exogenous estrogen administration. He may take something from estrogen, because now, with the endocrine disruptors that are due to the pollution of the atmosphere, we are exposed to estrogens, because all these disruptors act as hormones when they enter the body, and their action is estrogen-like. Estrogen-like. So, drug effects, some drugs that mimic estrogen, and another case is that the estrogen cannot be metabolized, and so it remains in the blood and triggers the ductular cells of the breast to proliferate. Which organ is responsible for metabolism? Which organ do we have to examine in this patient to see if there is a problem of estrogen metabolism? Where are all substances metabolized? Yes, please. The liver. So is some sort of liver deficiency there? Do liver cells do not work well and metabolize estrogens? So you see now, we have this clinical symptom, the increased size of the breast in a male patient, and that's all we have to think, and treat the patient accordingly.
Professor,
Yes.
does adipose tissue also promote the conversion of testosterone to estrogen?
Yes, if there is an increase in estrogens, they stay in adipose tissue. So, if the man is of increased body index, there is an increased possibility that estrogen are stored in the adipocytes and cannot be properly metabolized. Yes, please.
I want to ask if there's dietary, when you take estrogens by diet,
Yes, what does this mean?
like
For example, if this man takes some substances with hormonal action, for example, if he is an athlete of bodybuilding and he takes some supplements so that he increases the muscle size, these may have some estrogen. What else? From the adrenal glands. The adrenal glands produce steroids. The zone, I don't remember exactly, you know it better from anatomy, the cortex, not the two first zones, the one that is near the medulla. That's right too. Okay. Don't tell the histologists they won't pass the exam. Don't tell them I didn't know. That one that was down near the medulla. Don't tell them. Yes. Well, let's hear. Now we have the kidney. Look, there is a young man with high fever. Here is his temperature. This is the murmur, is something you listen in the heart. You put the stethoscope and you have some sort of murmur during the whole systolic period. Have the blood culture. You see? Positive for Kotsi, yes. I'm not sure I understand all this. You'll have this in microbiology. Have a look here. catalase negative alpha hemolysis when grown in blood agar. This is what the microbiology lab takes and makes the culture to see what is the infection agent, to identify the agent. You'll learn this in microbiology. And we have a urine examination which reveals red blood cells, but not white blood cells. If we had white blood cells, which are white blood cells? We'll talk to them in our next lessons. Polymorphs, lymphocytes, that would be infection. However, we have no infection, despite the fact that the patient had an infectious disease. Why? Because there was something wrong with his heart, and he had a positive blood culture. However, we do not have bacteria in the urine, just red cells. Okay. What is suggested by the history along with the blood culture results? So you think about the four cavities of the heart, right? The ventricles and the artery. They have, which is what connects in each part of the heart, the right heart and the other. Yes, please? The valves. So there is something wrong there of infectious. And when we have infection, the inflammatory cells go there, and the inflammatory cells, what do they have in their cytoplasm? They have enzymes. So when these enzymes come out of the cells, they make the tissue soft. And what is the consequence of this? What is the consequence if the tissue is softened? It is cut. So what do we have here? We have a piece of tissue that leaves the left ventricle. Where does it go? If it goes up, it goes the carotids, and we have a problem in the brain. If it goes down, it follows the arc, all right? It goes down the celiac aorta, it enters which is the artery that gives blood to the kidney, the renal. It enters the renal artery, then goes in the kidney, and follows the branches of the renal artery. Have you any idea the branches? There are the interlobular, those the ones that go, those that are like that. How do they say angulated? I'm not sure. Arcuate arteries. And look what happened here. So this is the renal sinus. This red, in this white tissue, which part of the kidney is that we see? Mucosa. This is mucosa in the kidney. Remember the first lesson? We said that if there is a cavity someplace in the human body, the first layer is the mucosa. You remember in the kidney, what is this mucosa? The white one. Have a look here. Do you remember which mucosa it is? It's the renal pelvis. There's nothing wrong with it. What's the wrong here? This is the wrong. This thing that left from the heart went and blocked this artery branch. All right? And what is but this happened not on a chronic base, so that it becomes atrophic. It happened acutely. And what is the result? Have a look at this area. Have a look here. This is the wedge-shaped area, and this is excellent. This is ischemic necrosis. It's called in pathology coagulative necrosis. And when does it happen? If the blood supply in a specific part of the body is acutely disrupted. That's right.
How do we know that the tissue that was damaged and left was from the heart?
How we know? We had the murmur. Look, you examine the patient. The problem was in the kidney and in the urine. However, the problem is in the kidney, but always remember to examine the patient as a whole. The problem is in the kidney, because he felt a pain, he had red urine, so we have a problem in the kidney. However, the human body is a total thing. Okay, we have a symptom, a finding. We are obliged to examine the whole body, because here we have this murmur at the heart, so we presume that there might be some problem in the valves. We have the positive blood culture, and so we understand all this scenario that I explained. Yes, please.
I still don't understand why do we have ischemia?
Because we have embolism.
Yes, why? Why do we have embolism?
Because some part of the valve was cut, entered the blood, and went there and blocked the lumen of the artery. Is this clear?
Yes.
If there is somebody that cannot understand what I say, or my English, or there's some problem, he'll raise his hand and he'll tell me, say it again. It's my job to say it again. It's no problem if you don't understand. It's my problem. If you don't understand something, it's not your problem. It's mine. So you must help me solve my problem. Is that, yes, solve. Because I talk. If you don't understand what I say, you raise your hand. What did you say? You said, Trump will fire me. That's what he told me. He'll fire me, get me fired. Yes. Okay. So, this is a wedge-shaped pale area of infarction, coagulative necrosis, and here is the embolus in a renal artery branch beneath the lesion. And what happens now? A damage to small vessels near the infarct. What is this wedge-shaped area, the necrotic tissue called? It is called an infarct. All right? Caused bleeding into the calyces. Here are the calyces. That's why we had the symptom of red urine, hematuria. If you listen to hematuria, if you find blood in urine, what do you think? Of course, you can think of this, but this is not the most common thing. What else do you think? You think that there is, you think, what is the cause of hematuria? First, you would have a calculus.
Problem of juxtaglomerulus.
No, this is to have to do with the blood pressure, the glomerulus apparatus. To have blood in the urine means that something had destroyed what? The mucosa. Where does the kidney have mucosa? Renal pelvis, ureter. That means what leaves the kidney for the urine? Renal pelvis, ureter, urinary bladder, urethra. So, if there is some place there is a stone, a calculus, and it moves, it erodes the mucosa, and the blood vessels which are beneath the mucosa are cut. And so you have urine. That's the first you think. Particularly if you have pain. Because if the stone moves, it causes muscle spasm. And this makes a colicky pain. That means you cannot sit in a place. You want to move all the time so that the pain is less urgent. What else can explain hematuria? You have a neoplasm which grows and somehow is eroded within the urinary tract, so you have blood. And in another case, you have this. You have the ladin, you have, that is to say, you have infarction. So, if you have hematuria, you have the three things on your mind. These are the most common. We must always think of the most common, because if you open the textbook and see under hematuria, you'll have 500 pages. Yes, okay. You can study that. However, you must always think which is the most common cause. And if it does not fit, have a look at the Rex, 4,097 pages. Don't think at what is rare, because you know it, you've studied, yes. But to have the common cases in your mind. All right.
Professor,
Yes, please.
so, okay, we have the occlusion, but then how does the blood escapes into the urinary tract from the occlusion?
Excellent. Between us, I have not understood it myself completely. You have the necrosis. Why does blood come to the urine? So that's why I showed you the last sentence of the slide. Let's look at it together now. Look here. The vascular occlusion likely resulted from embolization of a fragment of the valvular vegetation. The valvular vegetation is the piece of the valve which was cut because it has become softened due to the bacteria that were there and the inflammatory cells. Damage to small vessels near the infarct. Have a look here. This is the infarct. All right? Can you see what color the surrounding tissue is compared to the rest of the kidney?
Dark.
Is that why? Because there is a zone of increased vascularity neighboring the necrotic tissue. So this zone near the infarct caused bleeding into calyces, and then we had hematuria. So that's the explanation, because that's correct. You told me if there is a stone, it erodes the mucosa and we have blood. If there is a tumor, it destroys the mucosa and we have blood. Now in the infarct, so the hyperemic zone on the edge of the infarct is responsible. Okay? Here is the coagulative necrosis. You see? It's not from the kidney. This is a case from the adrenal cortex. However, the mechanism is the same. What happened here? There was infective endocarditis, as in the previous patient. A part of tissue was cut, and it did not enter the renal artery, but instead it entered the artery that gives blood supply to the adrenal gland. So this is the area of necrosis. You see, we had an acute tissue hypoxia, all right? This happened abruptly, not on a chronic base. Because as we said in the beginning, if we have a chronic hypoxia, this most likely leads to atrophy. Okay? Now, here are the necrotic cells which have undergone autolysis and degradation. And when we have a destruction somewhere in the human body, leukocytes are triggered and they go there to phagocytose neutrophils and macrophages. But we'll talk of these two inflammatory cells in our next lesson, either on Friday or on Monday. We'll have a look at the announcement, as I told you. Yes?
So is both necrosis and atrophy reversible processes?
Necrosis is irreversible. Atrophy, theoretically, can be reversed if the supply is correct. It's correct. Yes. So, yes, please.
The infarct in general.
This is the infarct, right?
Can they cause necrosis?
The infarct is synonymous to necrosis. All the infarcts, after acute blockage of blood supply, are of coagulative necrosis. That means how we look at the tissue in the microscope. In coagulative necrosis, we have a shape of the ghost cells, of how cells, their contours were before the infarction. In other type of necrosis, we do not have these microscopic findings. The organ which has an ischemic necrosis, which is not of the coagulative type, but of the liquefractive type, it liquefies, it makes it liquid. It makes the tissue liquid, is the brain. All right? Here, if we have abrupt blockage of blood supply, there is necrosis, but not coagulative like here, but like in all other organs of the body. Yes?
How long does it take for necrosis to happen?
It's a matter of minutes.
Okay.
2, 3, have a look and tell me. But my kids, I do not know everything. Huh? Like you, who cannot know everything. We have to admit that we do not know something. And some things we know, we must know them, not think that we know them. That's the key. Who knows everything? No, nobody. We must be eager enough to learn, search. Okay, Sarah? Yes. Now, and when time passes, there is organization of the tissue environment. We'll discuss this in our other lessons. And in the area where we had necrosis, it becomes connective tissue without many cells. Thus, it is called a scar. So that's the natural history of necrosis. The tissue is organized. We'll see in our next lessons which cell come there, and they form fibrous connective tissue which has no cells. Thus, it is called a scar. Yes. Here we have a 64-year-old man. He's about my age. Increasing dyspnea, that means shortage of breath. All right? For the last 12 months, for a year, problems. On examination, his blood pressure is, how do you judge these values of blood pressure? It's hypertension, right?
Yes.
So he has a permanent cause of problem. He does not take proper medication to make the pressure, the blood pressure values normal. He has a problem. Heart catheterization reveals elevated right-sided pressures with a right atrial pressure of 12 millimeter. We have the right atrium, all right? The right part of the heart. It has an increased pressure, as the catheterization shows, and the pulmonary capillary wedge pressure also increased. Which is the pulmonary capillary pressure? It's the pressure within the microcirculation of the lungs. So he had a problem of blood pressure, systemic. And at this time, we see that he has a problem of increased pressure in the right atrium of the heart and within the capillary vessels of the pulmonary circulation. Okay? The cardiac output is low. Have a look at the normal values, it's low. So what does this mean? There is not enough blood leaving the heart. This is the cardiac output. Now have a look at the heart. What is this? These cavities here. These are the atrium. Yes. Left and right. We have the vessels here. Can you, in anatomy, have you seen normal hearts? In anatomy?
No.
Have you touched them? No. You should touch the heart. Don't just see. Have a look. How thick the myocardium is. Because if you have the normal appearance of the heart and you see this here, what is the problem here?
Enlarged.
So it's thickened, yes. We say enlarged if there is dilation. Enlarged, it's correct, but it's a term we use when there is dilation of the ventricle or the atrium. Here we say it's thickened, and this diaphragm, the diaphragm between the two ventricles and the ventricles wall themselves. So they are thickened. Can you tell me why? Why? What problem did the patient have? You remember? What problem the patient had? Hypertension. How can this justify the thickening of the left ventricle wall? What do you think? Who wants to tell? It's not difficult. there is hypertension. What does this mean? That in order for the blood to circulate, it's more work, because there is an increased resistance in the peripheral blood circulation. So, who sends the blood in the periphery? Who sends? Which part of the heart sends? Sends the blood. From the aorta. Which part? Contracts and sends the blood. Which part? The left atrium. Not the ventricle, not the atrium. The atrium is near the pulmonary veins. The left. The ventricle is the one that contracts and sends the blood. Now that the patient is hypertensive, the left ventricle has a lot of work to do. That's why it is thickened. So, all right, this explains the thickening of the left ventricle. But here we have other pathology as well. We have an increase of pressure in the pulmonary capillary wedge, and then we have an increased pressure in the right atrium. What has happened? What's happening here from a hemodynamic basis? So, the heart is big, and we have severe hypertrophy in both ventricles, all right? And we have a dilation in both atrium, left atrium and right atrium. What happened? Up till now, we have justified the left ventricular hypertrophy. That's what we said, that the left ventricle had to work hard so as to overcome the increased pressure in the periphery, blood circulation. So, that's what hypertension caused. Now, the left ventricle compensates through hypertrophy. That means the size of the cells of the left ventricle has increased. All right. And the thickening of the ventricular wall. How do we see hypertrophy? We measure the thickness of the wall of the left ventricle. Now, left ventricular diastolic dysfunction, not systolic. Systolic is the one that pushes the blood to the periphery. The diastolic dysfunction due to hypertrophy results in what? Higher left atrium volume. The volume of the left atrium is increased. That's why it appears dilated, as measured by the pulmonary arterial wedge pressure. So, when we have increased pressure in the capillaries of pulmonary circulation, this is connected to high pressure of the left atrium. The pulmonary arterial and right atrial pressures subsequently increased as well, thereby, for example, now, if we have increased pressure in pulmonary circulation, which part of the heart is most likely to be affected? You'll find it. When we have systemic hypertension, the left. The left ventricle was affected to work harder. If we have increased pressure within the pulmonary circulation, which part of the heart is the one that sends blood to the lungs? Which part? You know it, Sarah? No, there's no problem if you don't know. No problem at all. That's why you are here. To learn. No problem. No? Which part of the heart sends blood to the pulmonary circulation? Which part?
Right.
The right ventricle. The right ventricle. So, this justifies what? The thickening of the other ventricle as well. All right. You see how simple it is? I'm glad. Okay. Perhaps I'm too simplistic, I know. But that's where we start from, okay? So we have, time is up, I know. Oh. Yes, time is up, time's up. So, we justified the right ventricular hypertrophy and the dilation of the right atrium, and we have a reduction in the cardiac output, which the left ventricle sends to the periphery because of poor diastolic filling from decreased compliance with hypertrophy. Yes?
Can you have increased pulmonary pressure without
Increased pulmonary?
pressure without circulatory increased pressure?
Yes, of course. In chronic obstructive diseases of the lungs. Be patient till the respiratory system. The effect is the same. The effect is the same. The right ventricle is thickened.
But does it cause the reverse also? Cause the left one to be thickened
No,
as well?
no. If we have the problem as in obstructive disease of the lung and increases the blood vessels in the pulmonary circulation, only the right ventricle is thickened. Okay?
Thank you.
End of lesson.
Thank you.
See you next time.
Don't go. I'd like you to check your name here.
Everybody's present. It's okay. Everybody's
One
present.
is missing.
One is missing.
Yes.
Oh no, we have to write down all the names now. Oh.